Good morning, everyone. If I could also get the first slide. So I've called my talk Dying with Dignity in Canada and chosen that title specifically because I want to try and illustrate that there is more to understanding the issue of dignity and end of life than simply talking about euthanasia and assisted suicide. But before I get started, if I could just have a show of hands, how many people in this room are worried about the timing and the circumstances of their dying? A show of hands? Okay. So the vast majority seem to be worried. Now, if the people in the front row, if you can just keep your hands up for a moment. Thank you. You represent about the proportion of Canadians who have access to palliative end-of-life care. Somewhere between 15 to 30% of Canadians have access to palliative end-of-life care. The rest of you, it serves you right for coming in late. The truth is that your death may not look quite as good because inaccess to palliative care is probably the reason most Canadians are going to suffer from a poor death as opposed to inaccessibility of a lethal injection or a lethal overdose. You may have seen, and if you haven't, you ought to pick up this week's copy of Newsweek. And on the front cover, you can see it's dedicated to the issue of euthanasia, death becomes them. And I'll quote from the article that says, in 2013, according to the latest data, 4,829 people across the country chose to have a doctor end their lives. They're talking about in Holland. That's 1 in 28 deaths in the Netherlands and triple the number of people who have died this way since 2002. The Dutch don't require proof of a terminal illness to allow doctors to help patients die. Here people can choose euthanasia if they can convince 2 physicians that they endure unbearable suffering, a definition that has expanded each year. Residents here can now choose euthanasia if they're tired of living with Lou Gehrig's disease, multiple sclerosis, depression, loneliness. The Dutch can choose death if they are tired of living. Now, I come at this not as somebody who claims to stand on a higher moral ground than anyone else, nor even claiming that my opinion about these things is any more important than anyone else. I am a physician, a scientist, and what I do is I like to study these issues around end-of-life care. This is a study that we did a number of years ago. This is looking at the will to live of a woman 80 years old with end-stage colorectal cancer. And in the far end of the slide, you can see that when she first comes into the palliative care unit, and the squiggly line is high on that far, on your left side, indicates that her will to live when she first comes into palliative care is poor. It immediately seems to improve as she enters into palliative care, and perhaps better symptom control is achieved and more support is offered. And then towards the time of her dying, you can see that her will to live becomes somewhat more erratic as death ensues. Perhaps even more profound and fascinating is that if we superimpose this same patient's subjective experience of her will to live and her subjective reporting of pain, the important thing you can see is that will to live and pain do this incredible intimate tango with one another, that as pain improves, so too does her will to live. And as pain perhaps becomes more erratic towards the end of life, her will to live begins to fluctuate at the same time. Now, we in our unit have done a number of studies over the years that have tried to really drill down and try to understand the experiences of people as they approach end of life. One of our early studies that appeared in the American Journal of Psychiatry looked at this notion of desire for death. It's interesting that in about half of instances, people said that they never thought about life ending sooner, but in the other half, at least occasionally, people had this thought that maybe it would be better for my life to be over sooner. The point that I'm trying to make is that all of us in medicine who deal with people who face catastrophic, life-threatening, life-limiting illness are dealing with people who are living with a certain amount of anguish and existential distress. The wish to no longer be here is an expression of that. So all of us in medicine have to be well-versed in understanding how to address people who are saying, I no longer want to be alive. It's not an infrequent expression that you hear. What we also found in this study, though, is about 8.5% of a cohort of 200 patients nearing end of life said that they indeed had what they called a genuine desire to die. What we found is that 80% of those individuals were experiencing pain of moderate severity or greater. They reported, at least subjectively, less availability of their family or support network, and about 60 to 70% of them met criteria for depression, compared to those who did not express a desire to die, in which the prevalence of depression was somewhere in the magnitude of about 10%. Dignity is an important issue for us to talk about, because if you look at many of the studies that have been done, and some of the earlier studies that have been done in Holland, loss of dignity seems to be one of the most prevalent reasons, at least according to Dutch physicians, why their patients might have sought out a hastened death. And so we decided, because it had never been done before, we should be talking to patients to try and find out their experience of dignity. If dignity is worth dying for, then clearly dignity is something worth studying. So what did we find? Well, we found that indeed people who lose their sense of dignity are in a great deal of psychological distress. They indeed do have a desire for death. They lose their will to live. But they also experience things like depression and hopelessness and anxiety. Something that we called intimate dependencies. The fact is that any of us who are ill at any times in our life are going to be reliant on others for these intimacies of care, bathing, dressing, toileting. And indeed, amongst those people who said that their sense of dignity was lost, these things were reported as being more problematic. Physical symptoms. People who are losing their sense of dignity are more likely to say that they are experiencing pain. In other words, the treating of pain is something that can mitigate a lost sense of dignity. Issues around bowel functioning, and even something as basic as, how I appear. This perception of how others see me in terms of my appearance. Now, this is a detailed slide, but it's an important one, and that is to say, if you want to understand dignity at the end of life, this is what you need to know. And what you need to know is that dignity at the end of life is not simply about making available to people a lethal injection or an overdose of medication, but attending, on the far left-hand of the slide, attending to their physical needs, managing symptom distress in a very exquisite way. And palliative care, by the way, is an approach that addresses quality of life, optimizes quality of life as best we can, as long as we can, for patients with life-threatening and life-limiting illness. The middle column deals with the very detailed psychological nuances. So what are things that can start to reinforce a sense of self? What can mitigate sense of hopelessness? Help people feel that their lives still matter, that who they are still matters. Attending to spiritual needs. And then on the far side of the slide, on your right-hand side, recognizing that we who are accompanying the patient have an influence on sense of dignity. So providing them appropriate support, something that we called care tenor, the tone of care. So those nuances of caring for someone that impart this sense of affirmation, that you matter, that you're important. Now, this is an extraordinary slide, and what you see is the reflection of an elderly gentleman, the eye of somebody who I imagine is a healthcare provider. And what we found in our studies is that the single most ardent predictor of lost sense of dignity is this notion of how people perceive themselves to be seen. In other words, if you look in the eye of your healthcare provider and only see your illness, you feel you've been reduced to nothing but your illness. But indeed, if you look at this picture, which I use to, really it's a representation of the logistic regression model, which would be far less interesting because you see lots of numbers and p-values. This is far more compelling because what you see is a reflection of an elderly man. He appears to be in his home, surrounded by books. There are pictures on the wall. He appears to have a past, a family. And what this is saying is that if we can show a reflection in the eye of the healthcare provider that provides this degree of affirmation, more so than anything else we found, and we looked at all of the variables we could in our study around end-of-life experience, this single thing is the thing that was most predictive of whether or not we could uphold dignity. Now, we reported this in a number of eminent journals, including the Journal of the American Medical Association. This publication was called Dignity Conserving Care, a New Model for Palliative Care. And it was interesting that it was not only extremely well received, but it was well received from unexpected places, including, at the time, one of the heads of the Hemlock Society, which is a right to die euthanasia society. And what she wrote in an editorial as a response to this article that we published is the following: still, if most individuals with a terminal illness were treated this way, the incentive to end their lives would be greatly reduced. So I wrote her back and said if she wanted to do fundraising for palliative care, we'd be happy to take those funds from the Hemlock Society and apply them in appropriate ways. Many of us, and our group is one of these, are looking at various different interventions and very nuanced psychological interventions that can start to mitigate end-of-life suffering, that can start to mitigate a sense of hopelessness, a sense of worthlessness and loss. And these things are very difficult existential issues for patients to confront near the end of life. This was a study of a new innovation that we've developed in Manitoba called dignity therapy. It's basically a facilitated short psychotherapy that allows the patient to talk about issues that they would want to leave and create as a legacy for their family loved ones. This sample was gathered between Canada and Australia, and what you can see is that not only were patients highly satisfied, but indeed in 76% of instances, patients reported a heightened sense of dignity, an increased sense of purpose, and half of the patients actually reported increase in their sense of will. So we have to understand that when people are saying, I no longer wish to be here, or life no longer feels worth living, that as physicians, that is something that is not unexpected in response to angst that people experience in the context of severe illness. And there are various approaches that we need to understand to try and mitigate that kind of suffering. Together with a colleague of mine, Dr. Keith Wilson, we did a national survey here in Canada. It had about half a dozen sites from across the country, so it's highly representative. There were nearly 400 terminally ill patients in this study, and there are 3 points that I'd like to make. And this was actually looking at dying patients' attitudes towards euthanasia and assisted suicide. Currently, within this sample of several hundred patients, 5.8% said, if it were available now, if you could offer that to me here today, I'm interested. The prevalence of depression, anxiety in that sample was in the magnitude of 41%. The other interesting finding that's buried in this in manuscript as well that I think is critically important when we're thinking about go-forward policies is that 9.5% of the sample, or 36 patients, said, had it been available during the course of my illness, I would have been interested, but I no longer am. So I think, the fact is that sometimes, well, not only sometimes, it's very difficult to predict the future. And what we know, if you, hearkening back to that first slide I showed you of will to live, is that the temporal stability of these things is something that we need to be very mindful of. Now, when we think about go-forward strategies and sort of the rhetoric we hear from people who are very supportive of this approach, they say, well, we can draw a line around autonomy. We can create restrictions that will prevent people from letting autonomy run amok. Again, I come at this as a data person. I don't have a political axe to grind other than saying we need to do better on caring for people near the end of life. That's my political axe to grind. And I'm not saying you should trust what I say any more so than anyone else, but let's look at the data. So what does the data say? Well, if we could read it from a distance, this is a test of visual acuity. This was a survey of 1,500 physicians, and these are general practitioner, elder care physicians, and clinical specialists. You can see that about 60% of them in general would say that they have performed euthanasia, and 86% of them said they could envision circumstances under which they would. In descending order, for cancer, about 56% of them said, yeah, I could see myself doing that. But then you start to look at what about patients who are psychiatrically ill? Well, about 2% say they have done it, and about 34% says, yep, under certain circumstances, I could see myself doing that. For patients with dementia who've entered into an advanced care directive, very few, but 30–40% are saying, yes, under circumstances, I could anticipate myself delivering euthanasia to a demented patient who is no longer competent, who wrote it into an advance directive. And in fact, if we go to the bottom of that list, it's looking at this whole new notion that's coming out about tiredness of life. And there is a very popular movement that if you are over the age of 70 and expressing tiredness of life, that you should be able to avail yourself of euthanasia and assisted suicide. This is not rhetoric. What does the data say? The data says that 2% of clinicians have actually delivered euthanasia in those circumstances, and up to 18% can envision circumstances in which they'd be willing to. Now, some people also say, in terms of the rhetoric, don't worry about this because places that have this legislation actually have really good palliative care. In fact, they have some of the best palliative care in the world. In fact, there's something about the connection between having this and palliative care that seems to be synergistic. In other words, if we do this, this will end up getting us better palliative care. I say, interesting, what does the data say? So this is taken from The Economist, and I think it's a relatively solid source of information. And I've actually looked at the authors and the informants, and these are really stellar palliative care clinicians and scholars without a political axe to grind. What do we find? Well, if we look at the availability of end-of-life care, what we can see, I've highlighted those countries where euthanasia and assisted suicide is available. I see one gentleman sort of craning his neck, and my admin assistant and I just couldn't figure out a way how to get it all landscape and still get it on the slide. So what you can see is that in terms of availability, Switzerland, Belgium look like they're performing okay. You see Canada at about 4.9, which out of on a scale of 1 to 10, I don't think is exactly where we want to be. But going down the list, Luxembourg, the Netherlands, Denmark at number 31. In other words, here's the evidence. This idea that somehow palliative care and euthanasia are synergistic and one makes the other better, the data just does not seem to support it. What about the quality of palliative care? Again, you see Canada, followed by Belgium in number 9 position, but then the Netherlands, Denmark, Luxembourg, Switzerland. And I think we can say the same, although in Oregon, again, there's a lot of talk about Oregon having excellent palliative care and in one study, a national report card, they seem to report very well. But then there was another study that was put out by the Means to a Better End, again, a nonpartisan organization who gave them good marks on advance directives, not overusing ICUs, training registered palliative care clinicians, but poor marks on a large number of nursing home residents in persistent pain, small number of hospital providing hospice palliative care, lack of state policies encouraging pain control and palliative care. People will also say, we can institute safeguards. Don't worry, we can make this safe and we can make sure that stringent criteria are applied and applied consistently. Well, if we look at the Death with Dignity Act and the reporting in Oregon, what we see is that beginning in 1998, and the most recent data is 2014, it's not on that slide, and if it were, you would see the number 0. In other words, this is how frequently clinicians are referring patients for psychiatric consultation who've made a request for assisted suicide. It began somewhere around 30%, and basically now it's fallen off the charts completely. Unless we can convince ourselves that somehow people who are making these requests over time are becoming less psychologically distressed, it seems to me the data is saying that people are just not applying the criteria stringently and people are not bothering to get opinions about psychiatric distress. Okay, so what about go-forward strategies? First of all, we need a national palliative care strategy in this country. We need to do a better job in end-of-life care, which means we need the resources to study, monitor, and evaluate end-of-life care. This should be included in facility accreditation, professional competencies, standard of care. This idea that we can call ourselves a state-of-the-art facility and yet not offer comprehensive quality palliative care seems to me unconscionable. We need to make real and substantive investments in palliative care. If you look at Bill 52, although they say that this is a bill about end-of-life care, the reality, it's a bill about medical assistance in dying. And when they talk about palliative care and making it available, the fine print says within existing resources. So that's not good enough. We need to very, very carefully evaluate what role, if any, there should be for physicians in this. I just had a recent publication in the Toronto Star in which I talk about the lack of competencies that physicians have. At our time of licensure, physicians have had less training in managing pain than do our veterinary medicine colleagues. Non-abandonment, as well as our most potent means to addressing suffering. I'm a psychiatrist. Over the years, all of us who deal with chronically ill patients and patients who are intermittently and episodically suicidal, after we've run out of drugs and after we've run out of fancy psychotherapies, the one thing we can offer is ourself, is ongoing, unwavering commitment. Have I saved every single patient in my career? None of us who do this work can make that claim. But the vast majority of patients that we look after, if we offer this commitment, that is the way we sustain people through suffering. It's not a quick fix, but it is the way that medicine traditionally has approached issues of suffering. I think we need to create a very separate designation for these physician-assisted suicide, or we no longer call it PAS, for these assisted suicide practitioners. There needs to be separate licensure, separate training, and judicial oversight, and I think the judicial oversight is important. Finally, the broader we make the criteria, the more likelihood it is that autonomy will run amok. These are not monsters in Holland. These are human beings who are trying to apply rules in the best way that they can, but they are applying it, as the data shows, to things like tiredness of life, dementia, mental illness. We also need complete transparency. The reporting from Oregon has been abysmal. We really don't know when these people actually are given a prescription. There is no way that these people are then reaffirmed at the time that they take their medication, whether they are competent, who's giving them the pills. If people have gone to a clinician and then they're turned down, there is no accounting for that physician to be able to report publicly what happens and why they turned that individual down. There's no reconciliation between physicians who say, yes, I'm willing to give you permission, and those who say, no, I'm not. So there needs to be documentations, whether they're granted, tracking, management, patient-level data and outcomes, public reporting, and finally a commitment to reevaluate what the data says and then to move in a direction based on that data. This is a photograph, a painting by the wonderful late Nova Scotia artist Robert Pope. He died of lymphoma. And when I look at this picture, I have a sense that he's probably contemplating what you and I are contemplating, that is thinking about life and likely thinking about death. Thank you.